Kwe, Sego, Annie, bonjour, hi. My name is Lila Cashew, and I'm the Executive Director of Dahan Dugon Sondoje, the Quebec Network Environment for Indigenous Health Research. We would like to begin this webinar by thanking our panelists who have agreed to share with us and with you today the research work they do. We would also like to thank all the people who are here in the audience and who share our interest in fueling discussions on promising practices that promote research environments by, with, and for First Peoples. We are currently in Jojoge, unceded Ganyangayaga territory, also historically visited by the Anishinaabe Nation. However, as our audience and panelists come from many places in the territory known today as Quebec, we invite you to share in the chat the Indigenous peoples who have shaped the land on which you find yourself today. And I'm going to pass the microphone over to my colleague, Audrey.
Thank you so much, Hila, for this nice introduction. So, Shego, everyone, I'm glad to welcome you today. I hope you all had a great long weekend and that you took this time to witness the beautiful colors that fall brings us every year. We welcome you today to our second webinar this fall of our series, Practical Examples of Research in Indigenous Contexts. Just as a reminder, in this series, we highlight research projects carried out entirely by Indigenous communities, organizations, and individuals, but we also feature research partnerships between academia and Indigenous communities and organizations, which is the case of our panelists today. I am really pleased to welcome Dr. Richa Shrivastava, who completed her PhD in biomedical sciences at Université de Montréal under the supervision of Dr. RI-MUHC, who today is the Dean of McGill University Faculty of Dental Medicine and Oral Health Sciences. Dr. Shrivastava is now Assistant Professor at the Postgraduate Institute of Medical Education and Research in India. So I'm just going to pass the highlight on you, Richa, and the floor is yours.
Good afternoon. Should I share my presentation? Good afternoon, everyone. I am Dr. Richa Shrivastava. I'm working as an assistant professor at Postgraduate Institute of Medical Education and Research in Chandigarh district of India. I have done my PhD from University of Montreal in oral sciences and under the supervision of Dr. LMME, as Audrey mentioned. And my project was on evaluation of integrated primary oral health services in Quebec Cree communities. I would like to acknowledge the Indigenous land by saying we would like to begin by respectfully acknowledging that the land on which this research was conducted is the traditional territory of the ERRSA-Qc. We offer our gratitude to the ERRSA who have stewarded this land throughout the generations for their care for and teachings about our earth and our relations. McGill also acknowledges that McGill University is on the land which has long served as a site of meeting and exchange amongst Indigenous people, including Haudenosaunee and Anishinaabe nations. We acknowledge and thank the diverse Indigenous peoples whose presence marks this territory on which peoples of the world now gather. We'd like to talk about oral health status among Indigenous population. If we see Indigenous population around the world, it is 0.6% of overall world population. But if you see the prominence of oral problems, dental problems, it is affecting more than 80% people are affected with dental problems. So there is profound oral health disparities that we can see in Indigenous people. If we come to the Cree community, in Cree community also the similar experience is seen where we found the dental problems substantially higher compared to the other normal Quebec population. If you see these graphs, the orange ones are the dental decays among Cree children, So here you see among all the children, all age group, you see the high prevalence of dental decay among children. If you see in second graph, in grade 2 and grade 6 also, significantly higher dental problems in Cree children, because the problems are very high. Treatment needs are also equivalently substantially higher in this population. Here you see it's a graph showing the dental decay from 1983 to 2012. You see, this is the difference. This is the per person. If you see average dental decay, this orange line is about the Cree people and blue line represent Quebec other children. So you see, even after so many 30, around 30 years, there was no change in difference between these two populations. And if you see in grade 6 children, this difference has even increased after 30 years. So we can see how profound these disparities are. So what is the solution? Solution is the collaborative approaches. For example, integrated approaches. How? See, whenever we have a problem, specifically in a marginalized population, in underserved population, you see the situation is very complex. There is not only one problem and one solution. So there are multiple factors that are affecting such problems, and there are the solutions cannot be only one solution. There are multiple things that are needed to be done. So we need to have collaborative approaches, and one of those approaches is known as integrated care approach. Integrated care approach is bringing together inputs, delivery, management, organization of services related to diagnosis, treatment, care, rehabilitation, and health promotion of the individual. So, integrated care, if you see in a health system, when we incorporate oral health, so things becomes very easy if it is successfully implemented, because in the same setup, patient can easily refer to the oral health services and vice versa from oral health services to healthcare services, and it also saves time and money. So that is how integrated care approaches are found to be very successful, especially in the situation where situations are very complex. Coming to the integrated care that is being utilized in Cree communities. So we see the Cree Health Board, they have their strategic regional plan since 2004, and they are updating this, and recently they have from 2023 to 2030, and their this plan mandates an objective of integrating oral health also within the primary healthcare system. So such kind of, first of all, integrating oral health into primary care, in around the world very few organizations have utilized this approach, and we appreciate Cree communities for utilizing this approach and integrating oral health within primary healthcare system. So this research project was conducted in collaboration with Cree Health Board to evaluate for the first time its integrated primary oral healthcare program. So I'm covering this presentation from what, so we understand what was the problem. Now, so what? So what is like, what were our research questions? So we targeted two things. First was, what types of integrated primary oral healthcare programs have been developed worldwide to address the need of indigenous community. So it is a general question that we had, where we try to identify around the world what is happening. And the second question was, how and to what extent does the integration of oral health into primary care address the oral health needs of Cree communities? So we have two questions. The first question, because it is understanding what is happening around the world, we use review approach. So here we reviewed the literature that is available, and we did a scoping review. And second question was based on uh, evaluating integrated oral healthcare system within Cree communities. We use case study. So one by one, I am going to discuss this. So briefly, I will discuss what was the findings of our scoping review. So we first of all used also indigenous health approach in our scoping review also, and we used two wide seeing approach. Two wide seeing approach is is a method that was also given by indigenous people only. And here in this method, it is said that with one eye we should see the western knowledges, and to the other eye we should look into the indigenous knowledges, and then we should see from both the eyes together. So in this way we will not just conclude based on only western approaches, and we will not conclude only based on indigenous approaches. However, we will gel together and we will come to a conclusion utilizing both the knowledges, western as well as indigenous knowledges. So we utilize this approach in our scoping review also. And based on our research, this review, we found there were around 30 programs, and they were mainly focused on oral health promotion, comprehensive dental services, also fly in and fly out dental services, where dental surgeons were fly to the community, remote communities, worked there for some days, some time, and they came back again to their place. Such type of services were also used in some programs, and some people have used teledentistry. Teledentistry is an approach where far-sitting specialist dentists, uh, with the help of a setup, they can see what is happening in the mouth of the patient, and they can suggest whatever possible treatments from the far by the fire setting dentist. Also, in this scoping review, we also identified the approaches that were used in these programs around the world from both the eyes. From the biomedical eyes, you see, we found out leadership, administration, capacity building, infrastructure technology, team working, coordination, and evidence based practices as the approaches. And in indigenous eye view, we found that vision on they were mainly focused on vision for holistic health, culturally appropriate services, community engagement, shared responsibility and partnerships, and cultural competency. And based on this, we came out with several outcomes: biomedical, mental, emotional, spiritual, oral health outcomes. However, we didn't find any literature that supports outcome on the spiritual uh, oral health outcomes. And our focus is our we recommend future researchers to focus on spiritual based oral health outcomes. The second question was to assess the integration of oral health into healthcare system in Cree communities. For that, we use case study. We use multiple case study design. Case study is like we have a case. Case can be an organization or communities, and where we try to understand the complexities within the organization or communities. So here we selected in Cree communities. We have total 9 communities. Out of 9, we selected 4 communities: Waskaganish, Chisasbi, Nemaska, and Mitsisini, and we assessed integration of oral health within these healthcare systems. Here we use qualitative approach. Qualitative approach is basically where we try to understand participants' perspectives. So here we don't just do numerical data collection and analysis. However, we here what we do is to understand participants' perception. So we do interviews and focus group discussions in depth and try to understand their perspectives. And because it is an evaluation process, we use developmental evaluation methodology, which is it's a this kind of methods is used for a complex situation where complexity usually changes the environment. So such evaluations are basically used in complex situations. So the health system in indigenous communities is considered as a complex situations because it is mostly affected by several factors, and there are several frameworks available to evaluate via developmental evaluation, and among that we selected appreciative inquiry evaluation framework. So what is appreciative inquiry? It's very interesting approach, and I found it very successful in indigenous communities based on my experience. So what we do usually, we use problem based approach. So whatever problem we have, we try to fix the problem. We have the problem, we try to fix the problem. But in appreciative inquiry approach, we usually don't look at the problem, we look at the strength. let's say in an organization we are evaluating something, so we will look at into the uh, strength, assets, any aspirations within the organization, and based on that we see what is working right within the organization, and based on that we move forward, rather than looking at the deficit or drawbacks and try to fix it. What we do here, we look for the strength within the organization and we try to move towards that direction. This not only helps in moving uh, positively, but also finding out some challenges also, and with the help of this positive approach only we can try to fix those challenges and concerns. So when we see appreciative inquiry, in my research project, I found it is in harmony with indigenous research principles. How it is in harmony with indigenous research principle is by saying that appreciative inquiry approach blends with indigenous people research. So appreciative inquiry approach, it helps to understand the it empowers individual indigenous population. Let's say we had participants from Cree communities, so we included participants as our co-creator. They were partners in our research, and we whatever we wanted, we co-created. So in every step of our research, is, let's say, starting with the writing protocol, then starting our data collection, how to do our data analysis, how we are going to coming to our conclusion. At every step we have conversations with the Cree community partners, and then we came to some our conclusion. Even whenever we were publishing our research, we had conversations with the Cree community partners, and if there were suggestions, we incorporated those suggestions also. So somehow it empowers, this approach empowers indigenous people voice. And that is why it is also like application appreciative inquiry in indigenous research. It is first time in oral health research we use this approach. However, this approach has already been used for other projects including travel, economics, in indigenous perspective, and indigenous people have also found this approach very successful. And as I mentioned, it is a strength based approach because we are looking at the strength and we are not looking at the problems. So we are looking at the opportunities and aspirations. So it's a positive approach. And that is also blends with the indigenous health principles. And appreciative inquiry is a mode of participatory research because the Cree community members were the partners with our research project, and it has a cultural analogy with the indigeneity, because here in appreciative inquiry we ask stories. You know, storytelling is very common approach that is used as a data collection method also in indigenous health research, and in appreciative inquiry also we use this approach where we ask oral health related stories from the participant. So it has cultural analogy also, and moreover the principles and assumptions that are mentioned by appreciative inquiry, they are very well coherent with the indigenous way of work. So overall I also feel that after doing this project also, it is not only literature says that it is in harmony with the indigenous health principles, but based on our personal experience also, I'm very sure to say that appreciative inquiry is in harmony with the indigenous health principles. So, appreciative inquiry approach utilizes four steps. First is discovery, as you see here, where we see what gives life to the organization. We appreciate that. Then we see the dream, so we envision the result. Then the third step is design, where we see what should be there after seeing the discovery and dream. So we co-construct with the partners, and then destiny, we see how to empower and learn and improvise for the sustainment of the project. So in the discovery phase, we had a planning meeting and video conferencing workshop. Uh, then where we identified what is working within the organization. In the dream phase, we had interviews and focus group discussions with participants like administrators, patients, as well as healthcare workers. And we asked their oral health related experiences, stories, and dreams for the future at the oral health service about the oral health services at Cree Health Board. In the design phase, we gave recommendations for action plan that was discussed with the and validated with the collaborators and our community partners. And finally, in the destiny phase, here we went partially where we recommended, and all the recommendations were given in the form of action plan to the Cree Health Board. Then coming to the result. In the result, in the discovery phase, we, as I mentioned, we discussed the strength, challenges, and way to improve the performance in the Cree communities about oral health, and we also discussed the evaluation model. And based on these discussions, we came to conclusion that we should use developmental evaluation. And in the developmental evaluation, we came to conclusion that we will use appreciative inquiry. This was the paper that was published based on our workshops and conferencing, video conferencing workshop. Then this is the publication that we had based on the major research question of this project, where we try to identify how and to what extent oral health was integrated within the Cree community's health system. So here we can say about the dental services. Participants appreciated quality of the dental services. They also appreciated co-location of dental services within the primary healthcare setup, as well as affordability because it was free for them. But they dreamed for immediate appointment because appointment was the time was very long. Then oral health was considered as a part of public health program. It was appreciated. However, they wanted more programs, especially for elders and people with disabilities. Participants also appreciated coordination among dental and non-dental care providers, especially during emergency cases. However, they wanted to have more accessible protocols and guidelines. Pertaining to management, participants appreciated appointment of Cree health workers and permanent professionals within the organization. However, they wanted to have more permanent and Indigenous or Cree employees. They also appreciated shared medical and dental records, as but they wanted to have digitalization of the records. They also appreciated developing advanced technology and infrastructure. So, but they dreamed of having new bigger infrastructure where it was not available that time. Third was main important point was emphasizing culture. So participants appreciated the focus on integrating traditional practices into health services by Cree Health Board organization, and having non-Cree professionals learning culture with their own experiences was also appreciated. However, they dreamed for integrating cultural oral health practices also to the care delivery, which is usually not done. But here they dreamed of, and they also suggested many oral health practices being used in on a cultural basis. And they also dream for learning about traditional healings from the elders. Other than this, we also had publications based on patients' perspective about this integration, also on relational continuity and anthropological perspective. I will just briefly tell about these add-on projects. So in the patient's perspective, we ask patients how they feel about this integrated oral healthcare system within Cree Health Board organization. So patients suggested and they supported the importance of patient-centered care in integrated care because patients feel emphasized when they are working within such system, and when they feel comfortable also. Patients highlight the importance of respecting their perspective in clinical decision making. They also highlighted importance of integrating indigenous personnel in the dental team and optimizing care coordination. And participants also emphasize on cultural sensitive care, development of more supportive environment, and they wanted parental engagement more into the oral health promotion. Relational continuity, we also had a add-on project on relational continuity. Relational continuity is basically a care when we have a dentist or a healthcare provider and a patient. So when we have the patient doctor patient relationship, it only can become successful when there is a continuity over a time period. So, relation continuity is a concept which tells that how patient-doctor relationships goes on over the time. So, when we try to identify this relation continuity within the organization, so participants suggested culturally having culturally competent professionals and working across professional boundaries, because participants, many of the health workers, they were so enthusiastic. They were referring patients and trying to see how the patient is getting treated after being referred. So they were themselves having they working beyond their professional scope. So that was appreciated. And having proactive organization engagement, Korea Health Board definitely is working proactively in this. So such things were enabled to have relation continuity within the healthcare system. However, impermanence, because most of the time healthcare professional may go or they are just for the temporary period. So such cases usually negatively affect the relation continuity, the patient doctor relationship. And also lack of effective communication, sometimes having dental healthcare professional or dental healthcare professional from non-Cree origin, sometimes they may have not very effective communication. That was also one of the barrier that was considered by the participants. Another add-on project was on anthropological perspective of MIPMA tissue and the integration of oral health in primary care within Quebec Cree communities. This we did along with the experienced anthropologist. She came with us, and she worked on our like interviews, our transcripts, and she helped us in identifying the anthropological perspective of primary healthcare integration. So we got some interesting results from this perspective. So basically, in this project, we explored participants' perception about primary healthcare conceptualization, culturally based approaches and experiences about the oral care services using two-eyed seeing Indigenous framework. As I discussed in my scoping review, also we use a similar approach. Here also we use a both eyes, Western knowledge as well as the Indigenous knowledge, and we use this two eyed seeing approach here also. And we found out three key factors that were very important in integrating oral health into primary healthcare. So first was Cree perception about the primary health and oral health care. So it was very interesting to find out that Cree people, they perceived household as the unit of care, whereas non-Cree people views healthcare service like health system as a unit of care. So usually this is how we see how the Indigenous culture is. And also they emphasize on cultural safety. Also third point that came out from this project was health provider patient communication and role of silence, because even for us it was very interesting, because when we were going for the interviews and focus group discussions, the role of silence. So we stayed there for some time, we interacted with the people over there, and it was very healthy communication discussion also, other than the data collection. So we understood the meaning of silence, because sometimes you will see the the Cree person is not speaking anything and they are thinking and then they are replying. So usually it is not in our way of Western methodology. So we usually don't wait and we just go ahead. But by staying there, interacting with them, we also understood the role of silence, that is very important. So they usually have the silence to think what is happening and uh, how basically they are thinking about whatever we are asking, and then they answer. So that helps us also to wait, and then to understand how, because this also helps in understanding cultural safety and cultural competency. So so I think these were main key factors from this project. So coming to now what is recommendation. So in our last phase of our appreciative inquiry phases, there we recommended action plan to the uh, uh, Cree Health Board partners. They also validated our action plan. And these plans were mainly focused on increasing promotive and preventive services, having faster access to dental care services, improving management, better coordination, and promoting cultural integration. So we had several points how we can work on these broad headings. So we submitted our detailed action plan, and it was very well accepted by the Cree Board Health Organization. And when we see what is happening right now, so this is from the recent annual report of Cree Health Board, where you see they are using this MIPMA tissue integrated care model. They are they usually have a age-based healthcare model, so they are providing age-based services, but now they are changing it to MIPMA tissue integrated care model, and it is very well related to what we have also done, integrating oral health within the primary healthcare system. So I feel very proud of what we have done and how it is being implemented within the community. And they have already started it in Chisasbi and Mitsisini. And as per the annual report, people were really happy to have such kind of model within the community. They are getting very positive response. So to conclude, I would say Cree Health Board organization has been successful in implementing strategic planning on oral health integration into primary care at all the levels of integration. However, the organization definitely needs further strengthening for its full integration of oral health within the primary healthcare system. These are some memories from my research project, and I would like to acknowledge my supervisors, Dr. Imami, as well as Dr. Couturier and my committee members, all the study participants and my funding agencies. Thank you so much. Merci beaucoup.
Mhm. Uh, Thank you, Richa, for this great presentation. I really like how you really used a strength-based, asset-based approach that was culturally sensitive throughout this project, and how the voices of the patients were also highlighted and recommendations. And it's great to see that this project was action-based in the sense that, you know, it led um, to actions, implementation of recommendations to enhance, promote not only oral health, but, you know, global health of Korea, EU.
Yes.
Yeah, it's so thank you so much for this. Now the second group of panelists we are welcoming today is Dr. Ivan Litvinov, who's a scientist at the Research Institute of the QUSUM and an associate professor at the Department of Medicine at McGill University. He is here with Alexandra Kelly, who's a project manager for a new project that they will discuss today. So I will add a pin on you, and I will find your colleague.
We're here. I see Alexandra here, myself. If I can be made a co-host, so can I share the screen?
Absolutely.
But first, I want to congratulate Richa on the wonderful work. It's really inspiring for what you've done. Seems like a meaningful work. I mean, oral health touches on everybody, and having something concrete presented like this that really changes the mode of delivery care is really going to be impactful for these communities for years to come. So
Thank you.
congratulations. Our project is recently started. We actually in the process of data collection. I'll do the first presentation of about 10 minutes of what the project is about, as we would usually present it to the health boards that provided approval for this work. And then Alexandra, after that, the project manager who actually spent the entire summer in 4 communities in Nunavut, in Gujarapik, Saluit, Inukjuak, and Kuujjuaq, will share some of her experiences and probably will echo some of the points raised by Richa. So without further ado, let me just see if I can share my screen. Can people see my presentation? Yes, no, somebody can. Okay, so what is skin? And I would argue that diseases manifesting as primary, secondary cutaneous complaint
We're not
constitute.
seeing, Ivan, we're not seeing the presentation.
Okay, so that you see, that's the beauty of Zoom. Give me 1 second. Some technical difficulties. All right, let's try that. Okay, I think now it should work, right? Okay. So these are some pictures, as you can see, of skin and skin diseases, in Indigenous culture and in our culture, in Western culture. Here's a patient affected by vitiligo, as well as this patient. You can see that skin is very much represents ourselves, our inner core, how we define ourselves, how we present ourselves. So here's a child with a painting on his skin, some of the traditional drawings highlighting how we depict the skin to portray our world. And being myself from the University of Kentucky, here is a typical picture from a basketball game at the University of Kentucky, and you can see that we color and display our skin in different ways depending on a world around us. So skin diseases are very common, and diseases manifesting with skin represent about 15% of all outpatients visit to family physicians. And according to 2023 statistics, there was over 100,000, 102,000 people waiting to see dermatologists in Quebec. In 2024, this number is actually 105,000. So we're going in the wrong direction. In 2018, it was 80,000. So the wait list for dermatology is actually getting longer. Skin is the largest organ of the body, and often our skin signifies overall the wellness, the health, the beauty, the affluence in our society, just like teeth in many ways. And like I said in the previous picture, we highlighted that physical attributes of one's own skin contributes to the spiritual core concept of self and others. How we present, alter our skin, hair, and nail appearances with clothing, styling, makeup, coloring reflects a spiritual, cultural, societal dimension that in turn is associated with our self-concept. And all individuals will be affected by skin disease, whether benign or malignant. And here are some examples of alopecia, vasculitis, immunobullous diseases, eczema, lupus, or dyschromias that we can see in patients. So this is the overall wait list for dermatology in Quebec. And as you can see, it is substantial, over 100,000 patients waiting to see a dermatologist. What is, of course, common in our province is that all the health services are located in the southern portion of the province. So all the dermatologists in Quebec are located here, and there's no dermatologists actively practicing in the Cree or Nunavut territories of Quebec. I go sometimes, some other people go, but we don't really have an integrated healthcare system developed for up north in a way that the dentistry has accomplished. Also, we know very little about Indigenous dermatology and how it impacts population. So we know that there are significant concerns related to a number of diseases, hidradenitis suppurativa, atopic dermatitis, infestations such as scabies, leg ulcers, et cetera, et cetera. And many of the conditions that our patients suffering, here are some pictures that I have taken of patients from my trip up north, are basically affecting not just the patient's skin, but their psychological health, and sometimes affecting the entire family. So if the child is affected by eczema and cannot sleep, that means the entire family cannot sleep. Then the child has difficulty, functioning in class, has difficulty, playing or, interacting with others. So you can see how some of these diseases of the skin affect not just the individual, but the family and the greater communities. And there are available treatments, advanced treatments that are quite safe and culturally accepted, like light therapy, UV light, that can be used to treat some of those conditions, but due to lack of established care, we don't have a way of bringing some of this treatments to our patients. So here's an example of a patient with psoriasis. Today in Montreal, if you have psoriasis, we have effective treatments. We basically will eliminate disease. So you need to go from the skin covered with the disease to basically clear skin. So this is the time to sort of bring this treatments and work with the communities to co-develop integrated care. Also, we know very little about how the diseases affect the communities, like I've mentioned, the nature of the diseases, the degree to which they affect the communities. We know how eczema, psoriasis, other diseases affect the Western world, but we have very little knowledge about Northern Indigenous communities. So in fact, if you type in Indigenous Dermatology Canada, you'll get 7 results, and you can see many of those are actually unrelated or erroneous. So we're actually lacking data. We are fortunate in Quebec because we do have the RI system, and McGill is assigned this large segment of a territory, which does include Nunavut and Cree territories of James Bay. And so we do have an infrastructure for dermatology, just like dentistry, to go to the territories to provide care for these patients. But unfortunately, this time, the dermatologic services at the territories is very limited. So we were able to receive a grant from actually Denmark, and Denmark has similar challenges of establishing care in place like Greenland. And of course, for the Denmark, for Copenhagen to Greenland, it's a longer flight. So they actually supported our effort to develop dermatologic care in Northern Quebec Indigenous communities, hoping for our success to then be tailored to experiences for patients in Greenland. We've started the discussions for the need of the project, meeting with elders, with community leaders in Cree territories and in Nunavut. Discussing from the very beginning what the projects would look like, what would be the input from the elders, from the Indigenous patients, from local healthcare providers. And you can see here some of the pictures through town halls, meetings, and discussions that were held. And we will be proposing to have to establish a learning health system where essentially we started some of this work. We're gathering data. We're going to analyze the data. We have a steering committee that is being assembled from Indigenous elders and leaders that will where we present this data. The Indigenous steering committee will then provide recommendations that will be implemented by respective health boards. And then we close the loop and restart the process again. And we hope to do this every 6 to 12 months. And in the process, we want to make sure that we are incorporating collective knowledge for better treatment outcomes and incorporating Indigenous knowledge. The project is aligned with First Nations principles of OCAP. So all the data that is collected is actually owned by the communities where the data is originated. Anonymized data is basically presented back to the communities. And we want to make sure that we're building close rapport with patients and finding things that are appropriate for them. Sort of like this two-eyed approach that was presented, where we're looking at things with an Indigenous perspective, a traditional knowledge, community knowledge, as well as Western perspective, and saying, well, before we recommend, topical steroid or moisturizer, if the family is using bear grease or seal grease, maybe this is appropriate. And, or maybe if there's an ulcer, maybe we can use a manuka honey or a fish skin as a dressing, if this is what the patients prefer, as long as it's done correctly, and incorporate some of the acceptable treatments, such as, from the plants and UV light to the community, and then talk about additional targeted treatments that are available for those communities. So we've identified 10 diseases that are common and affecting a large number of population here, as well as up north. And working with our steering committees, we developed some benchmarks that we're hoping to work with in the next few years with through the Learning Health system and steering committee, and in order to improve care for those diseases. And I believe that if we improve care for those 10 dermatologic common diseases, this is actually going to be reflective of a much larger number of dermatologic diseases, in the area. So because if the infrastructure is there to care for those 10 diseases or 10 groups of diseases, that means other diseases coming in probably will be well addressed by the service. We hope to analyze our success through focus groups. The importance of storytelling discussions have been highlighted by our previous presenters. So we have started some of this work in Nunavut. And then develop educational resources for the communities, as well as for the healthcare providers in the communities through knowledge mobilization. So in the end, we're hoping to create a community of concern and a community of practice for skin disease. So in other words, as Alexandra will highlight, people are just starting to think about skin diseases in, Nunavik communities. They have not been really approached this. So, realizing that skin diseases are important, that are treatments available for the members of the community, that such and such member went and got treated and they're feeling better, and this member and that member. So people are more likely to seek to understand and to provide, to find care and understand that the practitioners will provide culturally sensitive care, recognizing the community knowledge and values of the community, and the community practice, meaning who does what. Where to send the patient to Alexander, where to send the patient to me, where is another provider. So it's not, lost at sea. People know who to contact to solve this particular problem. And building trusting relationship. And we hope not to do this alone, but also by engaging existing patient support organizations across Canada, by encouraging them to develop web pages and partnerships with Indigenous communities. So I'm going to pause here, and before going to about anticipated project outcomes, pass the torch to my colleague Alexandra, who actually spent 4 months in Indigenous communities, to provide some of the reflection on the work that she's done.
Good afternoon, everyone. So yes, my name is Alexandra Kelly. I am the project coordinator. I myself and a team of other medical students, we were in 4 Inuit communities of Nunavik, Salawit, Kujarepik, Kuujjuaq, and Inukjuaq, where we hosted focus group sessions with community members. We did quantitative and qualitative analysis through surveying. So we were interested in seeing what kind of sun protection measures are currently implemented in communities. Are we protecting our skin? What are we using? Is it available? We also delve in deeper with what skin conditions are most prominent, as Dr. Lipinov discussed. And then we further followed up with participants for both sun protection and skin disease focus groups, and asking them about traditional methods, what methods are available in the community, what do people want to see more of, and how can we co-integrate better dermatological care within these remote communities. We created steering committee boards in each community that helped guide and lead our teams to be collecting data in a culturally sensitive approach. We organized various dinners and country food events for the communities, which was very entertaining. We loved to see everyone come out, and we were able to connect with the community in a more broader sense. A lot of people came out to these events. They were interested in helping us and seeing the work that we were doing. We did further investigation through resources that were in the communities. So traditional knowledge with elders and within the books that they had there. And now we are, as Dr. Lipinov said, in the process of data collection, data analysis, and creating these qualitative and quantitative papers. And with the help of the steering committee members, also integrating a traditional methods encyclopedia of ways that healthcare providers or community members can look in this book, or even online in Inuktitut, English, and French. And yeah, that's a little bit about the work that we were doing there.
Great. And so I'll just close, saying that this work will be cyclical. We will be doing this for some time. And the anticipated outcome of the project is we hope to not do this alone, by work with qualitative scientists. So we work with Dr. Paylas, who is an expert in psychology and self-help, and work with Indigenous communities. We work with biostatistics, Dr. Ilham Rami, who's our epidemiologist, helping us analyze the data. We have partnerships with rheumatology, allergology, infectious diseases that share the skin disease skin space. And of course, the most important thing is by working with the communities, with the Indigenous partners, understanding their priorities, which diseases at what time, how they should be treated, to develop this healthcare delivery system to advance the quintuple aim for health equity for the served regions. And we hope to really build this from a ground experience, and as a result, establish something that will last for years to come in a similar way that was achieved by Richa, our prior presenters. So we are aspiring for a similar outcome, but for dermatologic disciplines. So I'll stop here, and I guess, Audrey, what's next on our agenda?
Well, the next part of the agenda is the Q&A. If people have questions, I just want first to thank you for this presentation. I know you're at the beginning of the project, but I love how you already involved elders and community leaders as part of the steering committee. I'm looking forward to the results of this study. So let me remove all the pins and have a more I don't understand how to work this thing today. So multi-speaker, nope. Immersive, nope. Gallery, here we go. So I don't know if anyone in the public has questions. Je ne sais pas si les gens dans le public ont des questions, des commentaires. Ne vous gênez pas, on a encore beaucoup de temps là, pour passer à travers quelques questions.
Sorry.
Don't worry, Richa. What about you, Leela? Do you have any question, comment? No?
Yeah, I think I can go with the question.
Yeah, go ahead, Paul.
Go ahead.
So hi, everyone. I'm Paul Wanka. Excuse me. And I just recently started my appointment as assistant professor at the Faculty of Dental Medicine and Oral Health Sciences with Dean Imami. And I'm really interested in health equity research and with a particular focus on Indigenous research too. So I think my question, it's put to Dr. Litvinov and Dr. Shrivastava, like for an early career researcher who's actually starting to carry out research within Indigenous communities, like how did you navigate establishing these connections and actually carrying out the research?
Richa, do you want to start, or and then I can weigh in? Oops, we lost Paul.
You can please start. You can add on that.
Well, in my case, basically, I think going to the communities to provide care and being there in the communities and talking to patients, and then gathering together in small groups, discussing whether this is something would be useful or not useful, is very important with local doctors and so on and so forth. So, it's hard to do it alone. So you have to be there. You have to engage with the people. I think some of the points have been highlighted as to what to expect, silence, the different understanding of questions, different perspectives. So you have to be very much respectful of that. And then once you have feedback and some people who will support you in the community say, okay, this is important, fortunately we have infrastructure such as this one, Global Health Research Consortium, so where you can talk to others, maybe look at the other protocols that people have prepared and then get inspired by those protocols or get inspired by the papers that are coming out and say, okay, so they have asked this question and this is the protocol and this is how this was done. If I have my question, what would be the way to proceed? And then obviously you need funding. So if you have the team and if you have the protocol and the infrastructure, then you can apply for some seed funding, and get a little bit of work done, maybe a paper or two, and then things will kind of snowball from there. So, but I think there's no substitute for boots on the ground, and actually doing things. You're not gonna get it right. And be patient, because this work, like from the point where we have an idea to the point, okay, we're actually going to the communities, it's 2 years, right? And maybe that's even fast, right? So, but it's 2 years at least. So be patient. So we understand that whatever you want to do may take 2-3 years to do. Richa?
Yeah, I second what you say. Even for us, we understood how can we proceed. It was possible only after meeting them. So we had, I am like Dr. Because I was working with Dr. Elmi Mami, she already started having, before me joining the project, she already started having the conversations and interactions and having a rapport building with the community. And then later on, I also got engaged with the project. So I was grateful that already they started it. So for me, having that initial resistance that we might see sometimes wasn't there, because my research team members already they started. But when I joined, even for me, initially it was because it was, for me it was overall a different experience, and I have never worked in such a like remote areas and rural areas. Though in India we have rural population, and like it is like 70% population in India is rural population. So, but it's very different from what we see in Canadian Indigenous scenarios. So, for me, it was totally a very different new experience. But having been there, discussing with the community members over there, talking to elders, talking to healthcare workers, even to the administrators at Cree Health Board, it helped us. It helped us a lot, because I think having a good rapport and having that very smooth relationship is very important to have a successful project. So, and it takes time. I agree with Dr. Evan that it takes time. So initial rapport, it takes time, but later on becomes easy. Even in our project, we have many members from Cree Health Board administrators, so they helped us in each and every step. So it became very easy for us, and we luckily we had funding from CIHR, so it was a very good project. So I really learned a lot from the project, and I'm very thankful to the project because of such an experience, and having PhD from the University of Montreal and having a supervisor who is at like dean at McGill University. It was all a good background for me to have a good position in India. So I'm very whatever I have learned in Canada, I'm definitely trying to use it in India, because definitely there are many different ways of doing research in India and how we do in Canada. So I'm trying to incorporate whatever I have learned in Canada in my research projects in India. And till now, I have not received any project in the indigenous population, but I'm working hard to have some to work with the indigenous population even in India. So overall, whatever we are learning, it definitely helps us to go further. So so I'm lucky that I did my PhD, and that experience helped me in having a good position in India. So being having working as assistant professor here, We are working with the ministry, like we are also directly working with the Ministry of Health and Family Welfare. So somehow the knowledge I have gained there, I'm using here. So, and that is helping me to, even now, helping me to go further in my early career, because still I am in my early career. So mostly it will help us go further, to gain more experience and work hard.
Thanks, Ivana, Richa.
Thank you for both these answers. Are there any other questions? Est-ce qu'il y a d'autres questions, des commentaires? Then I think we can end this webinar for today. It was a pleasure to receive. Oh, do you want to say something, Ivan?
I just wanted to thank you for having us. I've noticed that it's a small group, but I think all great things start small, right? So hopefully in 5 years, there will be 500 participants from all the faculties, but thank you for having us. Yes.